nomenclature has changed, and the assessment of mucosal healing is becoming more and more important. So I thought over the next little while, I'm going to touch upon diagnostic biopsies and some of the pointers in that regard, and then switch gear a bit about surveillance biopsies in the IBD setting. So this comes as no surprise to you, and you're all experts in this as to what the differences are for ulcerative colitis and Crohn's colitis, or better, Crohn's disease. And we don't really have to rehash that. But when evaluating biopsies, and biopsies being the key word for IBD, the primary goal often is to identify the location, the extent, the severity, and the presence or absence of dysplasia or even more sinister lesions such as carcinoma. The secondary goal, and this is mainly pre-treatment, is to identify the type of of IBD and determine the continuity of disease in the setting of pre-treatment. So the first question that I ask myself, are there sufficient abnormalities in this biopsy to warrant the designation of IBD? And so is the acute inflammation that is present in the biopsy really on the background of chronic inflammation? And so if that combination is present, then you're entering the territory of IBD. Is there an absence of features indicating an etiology other than IBD? And so this brings us into the whole realm of the mimics that could cause IBD. And so features of chronicity are architectural distortion, basal plasmacytosis, metaplasia, thickening or reduplication of the muscularis mucosae. Each one of them alone is sufficient for chronicity, but in combination, this is when they actually are sufficient enough to call something a chronic colitis. Now, remember that architectural changes really have to have a threshold of more than 10% in a biopsy. So a single bifurcation or a single branching crypt isn't necessarily enough in the absence of basal plasmacytosis or thickening of the muscularis mucosae to go into the category of having architectural changes. Whereas on the right side here, that branching that occurs in more than 10% of the biopsy in combination of that deep basal plasmacytosis certainly is sufficient to call it chronic colitis. Now, sometimes you can have branching parallel to the surface, so it becomes obscure to see what it is, and you actually cut it in cross-section and it looks just busy. That really just takes some pointing out to your technologist to sometimes reorientate the biopsy properly to get that branching present. So what are some diagnostic hints for UC versus Crohn's disease? So sarcoid-like granulomata certainly put you in the category of Crohn's disease. And then the pattern and distribution of the disease is very helpful. Past medical history, endoscopy, radiology, if present, all of those help in making the definitive diagnosis as to whether one is dealing with UC or Crohn's disease in that setting. And the distribution of disease is really the distribution within the biopsy fragment and amongst the biopsy fragments that are present. And communication is key, right? Our clinical colleagues are very good and trained in identifying the degree of inflammation, and probably the most common one is the revised Montreal classification. And so in my institution, we have through lots and lots of discussion and multidisciplinary rounds, now received that Montreal classification on our requisition form. So that we get something like this should no longer happen. And usually we point that out during multidisciplinary rounds that is of limited value. And the Mayo classification is good. It gives you a good indicator of the disease severity and also of the distribution if it's taken together with the location. And so in endoscopy, there's some hints as well. So supportive of Crohn's disease is obviously a significant small bowel disease component, segmental disease, severe perianal disease, and stricturing. And diffuse, continuous, as well as rectal involvement is more supportive of ulcerative colitis. So the distal involvement, the disproportionate small submucosal inflammation, the patchiosegmental disease, and the rectal sparing prior to any treatment, those are supportive of Crohn's disease on histology, provided you get that small bowel component as well. Whereas the diffuse inflammation, diffuse architectural distortion, most marked in the distal biopsies, and that atrophy and mucin depletion help you in the direction of ulcerative colitis. Now, there are some subtypes of IBD, and probably the most common one encountered is Psc Ibd as a phenotype. And this is often extensive pancolitic involvement and generally of milder severity. There's often a higher rate of dysplasia in those patients, and backwash ileitis, if you still believe in this concept, is more common. And then the right-sided predominant disease, if PSC is diagnosed first, and we'll talk about this a bit more in a second. And they also have a higher rate of pre-pouch ileitis as well as chronic pouchitis, and pouchitis in these patients usually does not respond to antibiotic treatment. And so this is now a bit dated. Almost 9 years ago, we did a study looking at the phenotypic expression of inflammatory bowel disease in patients with IBD, Psc Ibd. And what we identified is that the classical IBD PSC, where you have the pancolitic distribution, that really happens when the colitis precedes the liver disease. Whereas when the liver disease is present before IBD is present, you have a more right side predominant disease process. So in our cohort, it held up. I've since seen a couple of indications. And so it's my practice that if I see a young patient with a pancolitic distribution, I will raise the possibility that this may be in the setting of Psc Ibd, and if not already done, consideration to bile duct directed imaging and or studies may be considered. So we already talked about granulomata as a diagnostic hint, especially for Crohn's disease. And as you know, they are present in about 30 to 50% of the colonic mucosa of those patients with Crohn's disease. But granulomata are also in response to extracellular mucin, degenerated collagen, foreign debris, infectious organisms, or even drug-related. And there are even some authors out there who classify Crohn's disease in granuloma positive, given the rarity thereof. I don't really think that has caught on, so it might be a Canadian-specific idiom. So I do not subtype my Crohn's diseases in granulomata positive or negative, but just pointing out that granulomata, if you see them, aren't necessarily already equal to Crohn's disease. And not wanting in the postprandial state you might find yourself in going over the pathogenesis of granuloma formation, but really they are an accumulation of activated macrophages. And so the etiologic classification is long. And it's really the other category that we have to think about in the setting of colonic biopsies. And so here are the good examples of something that might put one down the wrong path, such as crypt rupture, and that's usually helped with looking at deeper levels or a second section over on a different slide. Mucin granulomata also can be mistaken for a Crohn's disease associated granuloma. And so then what are the pathological mimics of ulcerative colitis and Crohn's disease? So unusual presentation of ischemic colitis, as I show you down here, radiation colitis, microscopic colitis, infectious, diversion, vasculitides, especially Behçet's, and then acute self-limiting colitis. And then even in the polyposis disorders, solitary rectal ulcer may be mistaken, as can be inflammatory cap polyposis, juvenile polyposis, or given that I'm from Canada, I have to tell you about Cronkite Canada syndrome, which may lead somebody down to make the diagnosis of inflammatory bowel disease. And then especially in the infectious realm, for the uninitiated, amoebiasis and schistosomiasis, they can all be mimics of IBD. And Yersinia, if you're in the right side of the colon, especially in the terminal ileum and cecal area. Cryptosporidium, probably not giving you so much of an IBD. It's more of like in the realm of acute colitis type changes. And then definitely microscopic colitis, especially if they're long-standing and untreated. Both collagenous and lymphocytic colitis can look very chronically inflamed. And while trichrome is very helpful in the collagenous colitis setting, in the lymphocytic colitis setting, it may be quite problematic to draw the distinction between IBD and chronic lymphocytic colitis. And there again, the disease distribution and disease severity may be of help in making that differential. And this brings me to the point that proper sampling is key. And so this is what we in my institution ask for, and most of the time receive, is really if the question is IBD for a diagnosis, is that terminal ileum, right, transverse left, sigmoid, and rectum be presented. And rectal sparing is actually quite useful from a histological perspective as well. So here you see the sigmoid biopsy and just a bit over the rectal biopsy in the same patient. I think they changed the H&E that day, but it is the same patient. And so it's really helpful to make a informed diagnosis in that setting if rectal sparing is demonstrated. And also remember, it's very helpful if your endoscopist lets you know if the patient is using an enema, because enema effect can look very similar in some settings to proctitis. And so we show this every so often to our endoscopists during multidisciplinary rounds to, again, highlight how enemas may distort histology and make it so much harder if we don't know about it. Okay, so that was my part about some of the daily IBD biopsy struggles and the diagnosis, and shifting a bit now and talking about some of the surveillance biopsies and the famous dysplasia runs in IBD patients. So here is such a dysplasia run, and again, this was an outside requisition that came in, right colon, transverse colon, sigmoid, and rectum, 22-year-old man with change in bowel habit. I always liked when they put down that there was a change in bowel habit. Otherwise, I guess it was just a free colonoscopy. And so these were the biopsies received. And again, on low power, you obviously appreciate there's a chronic colitis here on the right side, as well as in the transverse colon. And while there's clearly an abnormality in the descending colon, it also has some hyperchromasia on low power view, and the rectum looks pretty normal. So again, in our pathology database, it showed that this is a 20-year-old woman. So it also changed the gender on the requisition with a past medical history of Crohn's disease, and she was originally diagnosed in 2015. She had been on treatment with prednisone, Imuran, and Humira, and all discontinued due to side effects. Currently on no medication, but suffers from 10 bowel movements a day. So truly change in bowel habits. And this was a repeat colonoscopy. And on the endoscopy report, it was mentioned that the ICV was narrowed and could not intubate or visualize the terminal ileum. There was erythema and loss of the vasculature throughout, and edema in the cecum, ascending and proximal colon. And there was a nodular area in the sigmoid colon, and biopsies were taken and submitted in a separate jar. So that was not mentioned on the requisition. So here's the right colon biopsy in a bit higher power. And I think we all appreciate that this is chronic active colitis. And here's that nodular area, the sigmoid biopsy. And so here is that likely nodular appearing area. And I show you this here in higher power. And there's clearly some dysplastic features present. So the sign out here was chronic active Crohn's colitis, low-grade dysplasia. And in the comment that was made that there is currently no consensus on the treatment of an isolated finding of low-grade dysplasia in a single biopsy from surveillance endoscopy. And while consideration may be given to colectomy, it appears the minimum that should be offered is repeat colonoscopy at a shorter interval with repeat biopsy series. And also made the mention that if high-grade dysplasia or low-grade dysplasia at multiple biopsy sites is seen at a later date, there would be a stronger case for resection. And if surgery is undertaking, the appropriate extent of the resection in Crohn's disease is unclear and could range from a limited segment that includes only inflamed bowel to the entire colon and rectum. I usually do not write comments that long, but I did in that case. So this is a second case before we go into some of the pointers, where we now actually have a clearly identified polyp present. And there were two, one in the right and one in the left. And we are being told that this gentleman does have colitis. And so here is the first polyp and the background mucosa, and here's the second polyp with this background mucosa present over here. And so again, we find out in the pathology database that this is a 61-year-old gentleman diagnosed with UC about 9 years ago, had numerous therapies, ASA as well as Remicade with limited improvement, and in fact has been steroid dependent for the last 8 years. There are multiple bowel movements throughout the day and night and no incontinence, and the outside colonoscopy showed those two polyps. So there's polyp number one at high power view, and clearly beautifully, at least beautiful in the pathologist's eye, dysplasia present. And then this is the second polyp over here on the left side, again, dysplasia present, but arguably a very sharp cutoff over here. And so the diagnosis for this one at this time was chronic active ulcerative colitis with both non-adenoma-like lesion and adenoma-like lesion. But this is no longer a diagnosis we should be making because we now have updated terminology, and the terminology of DOM should no longer really find itself into pathology reports. And a more proper diagnosis would be chronic active ulcerative colitis with multifocal polypoid low-grade dysplasia. And so the reason we are also interested in determining the presence or absence of dysplasia in IBD is the risk of colorectal cancer progression in both UC and Crohn's disease is directly related to the extent and duration of inflammation. And this is the scenario we all try to avoid. This is a resection specimen of a patient with ulcerative colitis, and you can see a hypermucinous change in dysplasia over here, and a mucin pool at the very bottom of the slide. And the next block over is the invasive mucinous adenocarcinoma in the setting of chronic IBD. And we know that the IBD dysplasia is actually quite different than the sporadic colorectal cancer. In fact, the molecular pathway is different, meaning that probably what we apply for sporadic colorectal cancer detection should not hold true for colitis-associated colorectal cancer. And you know this because our surveillance guidelines are different for non-colitis patients and which are followed up much more frequently. And this is a paper that is now also 4 years old, but to me, it's a fascinating paper that really demonstrated the clonal evolution of colorectal cancer and IBD arising from a single dysplastic cell in the epithelium. So if your endoscopists need any more good or convincing of the need of truly identifying dysplasia in IBD, identifying that single cell that might stop that patient going on for developing colorectal cancer hopefully might be of benefit. So I already mentioned that the terminology was rather confusing. We had ARM, DOM, and non-ARM, but fortunately, we don't have to worry about any of those any longer, because in 2015, the CNIC guidelines, and CNIC stands for the Surveillance for Colorectal Endoscopic Neoplasia Detection and Management in IBD Patients, came out with a consensus statement. And the consensus statement said that it was agreed that the terms dysplasia-associated lesion or mass, adenoma-like and non-adenoma-like should be abandoned. So I'm not going to ask you for a moment of silence, but really DOM has long passed, and as mentioned, no pathology reports should find themselves anymore mentioning DOM lesions. And so what is the recommended terminology? And so Scenic is helping us in this way, and it's really been accepted in some of the pathology literature that in visible dysplasia, we're talking about polypoid and non-polypoid dysplasia. The subtypes that our endoscopic colleagues are using, superficially elevated, flat depressed, I don't think they're particularly helpful in pathology reports, so polypoid and non-polypoid are sufficient. And now 3 years ago, we published a paper, again, Dom, rest in peace, on modern pathology, where we go into some of the details surrounding that. And if you're interested in it, certainly point you in that direction. So what are the Scenic recommended management for polypoid dysplasia, and why was DOM put to rest? Well, it really states that after complete removal of endoscopically resectable polypoid dysplastic lesions, surveillance colonoscopy is recommended rather than colectomy. And this is really the changing mantra. So it no longer matters if this is polypoid dysplasia arising in IBD, or this is a sporadic adenoma arising in an IBD patient with controlled colitis, because the key thing being, if it's endoscopically resectable, this patient would go on with surveillance colonoscopy. And so all of the data or the hints histologically that previously have been published but to differentiate a sporadic adenoma from polypoid dysplasia, while they're certainly not wrong, one could argue if it's resectable, they may not be of that much benefit to really subdivide those lesions. And so the management of polypoid dysplasia then really is, if it's a discrete polyp and it's completely removed and there's no dysplasia elsewhere, this patient goes on to follow-up colonoscopy, and anywhere between 3 to 6 months, although this might differ from institution to institution. If any of those are not the case, then consideration to colectomy may be given. And do pay attention that really it makes no difference as to the grading of the dysplasia being low or high grade in this setting. And we extend in our paper in Modern Pathology a bit more on that, but in essence, it's the same thing as I just showed you. If you're more interested in a more detailed for both random and targeted dysplasia identification, again, there's I think it's figure 2 in the paper. So while we're on the topic then, what are the Scenic recommended management for non-polypoid dysplasia? And interestingly enough, Scenic also recommended that after complete removal of endoscopically resectable non-polypoid dysplastic lesions, surveillance colonoscopy is suggested rather than colectomy. So even if it's a random dysplastic biopsy, if it was removed at the time of endoscopy, no further treatment at this setting. And the reason Scenic is so adamant about this one is because Scenic recommends that every dysplasia run be performed with chromoendoscopy. And chromoendoscopy, for those of you who are not familiar with it, is really just spraying a dye onto the mucosal surface. And so it's like fingerprinting in the old days, so you can really see any kind of alteration within the mucosal surface much better. And I'm not an endoscopist. I clearly don't see anything here, but I do appreciate that there's something in the area here with chromoendoscopy. And so studies have demonstrated that dysplasia is found much more commonly by using and deploying chromoendoscopy than not chromoendoscopy. Then why isn't chromoendoscopy being used all the time? Well, it takes more time to do it properly, and it takes more time not just to use chromoendoscopy in the dysplasia run, but also to clean the endoscopy suite in between endoscopies, because it is a dye and it doesn't always stay colonic. And so sometimes you find half of the dye on the floor. And so there is a resentment amongst some of our clinical colleagues performing endoscopy and doing chromoendoscopy, given that it has the potential to bump the slate. So this is why you still see a lot of debate, especially in the endoscopy literature, as to the usefulness of chromoendoscopy being deployed on every IBD dysplasia run. If that's the case, then should one still biopsy the surrounding mucosa? That the case being if it's resectable endoscopically. And this is a very interesting paper that came out of Belgium, and this demonstrated that there was incredibly low rate of dysplasia detected in the mucosa surrounding dysplastic lesions in those patients. And we don't have to belabor the point, but they looked at, they enrolled over 1,000 patients, and it makes a whole lot of sense, right? The belief that a polypoid dysplastic lesion is more severe if there's dysplasia present in the mucosa surrounding it always was very much operator dependent, because if this is the lesion and this is the resection line, there's what is close to the resection plane for one person is quite different for another person. So really the concept of polypoid biopsies in IBD dysplasia is of little value, and there's more and more evidence in the literature that it doesn't really add anything in stratifying the patient management. Now, another change that we see, and I specifically do not want to say the word dysplasia because the jury is still out as to where we're going, are serrated epithelial changes in the setting of IBD. And here's a good example as to what we mean. Again, it's sessile, so would not fall into the category of my earlier talk of a serrated adenoma, but there's clearly serrated epithelial changes present in this patient with colitis. Here's a high power view. You see probably some change from a hypermucinous change over here to a more traditional, if you want, serrated epithelial change. And here's, again, a high power view of that hypermucinous change. Now, we have known about non-dysplastic mucosal changes in IBD for some time, and this is a paper now 22 years old in Gut, talking about villous hypermucinous mucosa and long-standing ulcerative colitis shows high frequency of KRAS mutation. So we actually knew that those patients that developed that may have a higher risk of developing cancer, albeit as was a small cohort of 13 colectomies, and there was a very high number of high-grade dysplasia elsewhere present in those patients. And mostly we refer to those as hyperplastic-like changes. John Goldblum went on the record in 2000 to say that hyperplastic-like mucosal change is a diffuse expand of the flat mucosa with an architecture resembling that seen in hyperplastic polyps composed of cells with cytologically planned basal nuclei and apical cytoplasmic mucin distension. Again, having worked with John, I don't think he would ever write that in his microscopic description, but it's a very nice description as to what we see when we talk about hyperplastic-like mucosal change. And for the most part, this was just simply ignored, despite the fact that we knew that there were some molecular alterations within them. And in these authors' papers, they looked at 30 Crohn's resection with 30 matched controls, and they identified this hyperplastic-like mucosal change in about a third. And they had adenocarcinoma in that setting, and those that did not had adenocarcinoma had much less, but these are small numbers overall. And then once the SSAPs were discovered, we changed the terminology from some of the hypermucinous-like changes to serrated epithelial changes. And there's a real slew of publications that came out that really linked the detection rate and outcome of colonic serrated epithelial changes in patients with IBD. And the terminology became more accepted that this was serrated epithelial change. And endoscopists also started publishing it around 2016, really highlighting that there was an association between serrated epithelial changes and colorectal dysplasia. And this is probably one of the largest studies where they had 247 index serrated epithelial changes in 187 patients without prior dysplasia, and only 22 of those were endoscopically visible. The rest of them were identified on histology. There was some concordance between serrated epithelial change and dysplasia, and the author stated that there was a significant risk factors for developing dysplasia in older patients, especially male patients in a family history with colorectal cancer. And again, we don't have to go through this, but they were the first ones to really describe some of the histological changes as well as endoscopic changes of serrated epithelial change. So that then poses the question, do serrated epithelial changes have an impact on surveillance? And the authors tried to answer this here in 2016, and they concluded that KRAS was oft mutated in serrated epithelial change, but did not predict subsequent neoplasia. And again, we're going backwards, that it represents a hyperplastic phenomenon. So now that I have completely confused you on the topic, what do I do in day-to-day practice? So I recognize it as being present because I am knowing the fact that something has changed, I feel I should mention it. So I say chronic active ulcerative colitis with serrated epithelial change, and I see the comment. And I say that there is increasing evidence in the literature that this may represent a precursor lesion with the potential to transform. And I say that they may be regarded to be indefinite for dysplasia and offer that repeat biopsies within 3 to 6 months should be considered. But I also point out that ideally this should happen following the resolution of active colitis. And as you now know, I'm a big fan of chromoendoscopy. I even put that into my comment. Okay. After the dysplasia runs, I wanted to talk a bit about mucosal healing in surveilling biopsies, because that is a changing field, and I fear that we will not be able to hold the tidal wave of requirements from our clinical colleagues in subtyping the mucosal healing in IBD for much longer. So let me tell you what I mean by that. So, as you know, evolution of IBD is thought to be a progressive and disease, and that the complications increase over time, as we've earlier seen. Colorectal cancer increases over time. So up to 50% of surgery within 10 years of diagnosis, and 70 to 80% of surgery within 20 years of the diagnosis. But surgery is not without its complications, and especially in Crohn's disease patients, there's a lot of inflammation post-surgically as are after ulcers and clinical symptoms, and 30% of those patients actually will require additional surgery within 10 years. So it's really key to push that surgery date out as far as we can. But in order to do that, mucosal damage seems to be the one best indicator to actually determine as to at what point patients with IBD do require surgical intervention. And if we think about the goals of treatment, that is improvement in quality of life and the prevention of complication and reduction of hospitalization and induction and maintenance of remission, we arguably have a long way to go if diagnosis from us in pathology just states in the surveillance setting chronic active colitis and may indicate the severity thereof. And so mucosal healing is really been defined as based on endoscopic appearance. And that is a problem because there's no universally accepted histological definition of remission. And there's also no consensus on the optimal way to assess disease activity in those IBD patients. And so clinically, there are a whole slew of different disease activity parameters. And they even subdivide them endoscopically in ulcerative and colitis. And there are histological parameters. There's even over 30 in ulcerative colitis and several in Crohn's disease, but arguably they haven't really made it into day-to-day practice. And that really is part of the problem because we don't know how we define remission in IBD. We define it clinically as no rectal bleeding and clinical symptoms. We define it endoscopically, but we don't really know what the histological parameters are to say that this patient is in remission. And earlier this year, we published some data as to an international consensus on standardized integration of histopathology and ulcerative colitis clinical trials, with the understanding that mucosal healing is really of such paramount importance to understand the effects of new drugs coming into the pipeline. I do predict that it will, as I mentioned, find its way into day-to-day clinical practice in the not too distant future. And part of the challenges, and we won't go through all of this, but this was a very nice paper that just asked the correlation and remission assessment between endoscopy, histology, and clinical remission. And I draw your point, highlight for you here that the kappa between endoscopic and clinical remission was only 0.3. Whereas for histological remission and clinical remission, and this series actually had a much higher inter-observer variability. So it may be more meaningful in mucosal healing in ulcerative colitis, as it's predominantly a mucosal disease, and in Crohn's disease, this may not be applicable, might require more advanced cross-sectional imaging component to help fully describe the disease activity. But to answer the question, what is mucosal healing? It's the restoration of the normal mucosal appearance by endoscopy of a previously inflamed region and the complete absence of ulceration and macroscopic and histological signs of inflammation. And so the proposal for the International Organization for IBD for histological mucosal healing is the absence of neutrophils, both in the crypts and the lamina propria, the absence of basal cells, and ideally reduce the lamina propria basal cells to normal and reduce the lamina propria eosinophils to normal. And I can already hear you ask, well, what are normal numbers of eosinophils in the lamina propria? And this is how my academic career will carry on for a bit longer in defining what actually are the amount of eosinophils that might be considered to be normal. Now, as mentioned, we have some good clinical predictors of colectomy and relapse and ulcerative colitis, and we don't have to go through them, but as again, to highlight the point that endoscopic remission is not always correlated with a histologically quiescent disease. And we do see that in our resection specimens sometimes where we see rip-roaring disease and where it was just defined as complete remission. And interestingly enough, that basal plasmacytosis and neutrophilic activity in this study had a predicted relapse that was relatively high, and whereas patients without basal plasmacytosis only had 14% relapse. So again, highlighting the point that it's not just chronic colitis, it may be the tissue compartment where the disease, where the chronic inflammation is, that might be a predictor of relapse, but we're certainly not there yet, as is highlighted in the last statement. And I promise this is the last study on that topic, but I thought that it was very interesting that the histological remission may also be predicted in this study, the corticosteroid requirement, and even the hospitalization for severe colitis in those patients, not just the colectomy, again highlighting that there might be more value in biopsying patients to determine if they truly are in remission or not. So what are some of the histological indices? The very first one was as early as 1956. And again, I'm not going to bore you with the details. There are now over 30 histological indices for UC. And again, we will not go through all of them because in part, only 11 of those have been partially validated. Arguably, none have been fully validated because that would require follow-up and potentially resection of a patient. So an optimal histological index may not even exist for UC. So how should one document activity now? So I personally believe that we should mention crypt architectural distortion as quiescent colitis. If there's basal plasmacytosis present, call this chronic colitis. And if there are neutrophils present, refer to this as a chronic active or active chronic colitis. And in my practice, I subdivide them into minimal, mild, moderate, or severe. So we're certainly not yet at the level of requiring some of the more definitive subtypes, as I mentioned in some of the indices. But as I mentioned, I think the days will come where we will be required to do that. So I believe that mucosal healing is best categorized as a lack of disease activity based on combined endoscopic and histological assessment, complete remission, and that this precise definition histological has not yet been well established. Remember the amount of eosinophils present. And as mentioned, sooner than later, there will be at least a systematization of the pathological evaluation of IBD biopsies to identify remission. All right. So changing gears now from IBD to immune checkpoint inhibitor colitis. I know there's also terminology out there of immune-mediated colitis, but I think immune checkpoint inhibitor colitis, ICIC, probably captures what we're dealing with the best. So I forced myself to adopt that terminology, although I'm not personally a huge fan of it. Now, again, we don't have to go through the background of why or what's happening in immunomodulatory therapy, but it's here to stay, and you know it's here to stay when you find that, in fact, your financial advisor is sending you this, and that there's a growing interest of the global market for immune checkpoint inhibitors. So it's something that we as pathologists will have to deal with for quite some time to come. Now, there are, as you know, 4 drugs right now that are approved for the PD-1 and PD-L1 targets by different vendors. And it's ever increasing for immune checkpoint inhibitors in different organ systems. And in GI, obviously in the colon, it is we don't use a biomarker for it, but definitely in gastric cancers. Both the Keynote-1 study was very well received, and then in the Keynote 59, which was the follow-up as a monotherapy, we actually developed from that the CPS score, which is the combined positive score for anti-PD-L1 therapy in the assessment of PD-L1 IHC. So this is here to stay. This is not going to go away. But there is some heterogeneity in the therapy of biomarkers. And I just, as a little sidebar, our colleagues in the pulmonary realm have had some nice publications on that front, and pointing out some of the challenges as to the antibodies being used and positive cutoffs. So again, I don't want to belabor the point right now, but I wanted to highlight this one. And I've no commercial interest in Phenopath, but they have Phenopath as a very nice algorithm list to go through as to which PD-L1 antibodies might be used for which indication. So if you've not seen it yet, please do check it out. Okay, but so why are we talking immune checkpoint inhibitor colitis? Well, really the adverse effects of immune checkpoint inhibition are massive. And obviously in the colon, we have not just colitis, we also have enteritis and gastritis. And I know we're not talking about hepatitis right now, but in the GI world, both ICI hepatitis as well as pancreatitis are starting to emerge and are posing problems for the histopathological assessment. So in short, immune checkpoint inhibitor colitis is really happening if patients receive anti-CTLA-4 or anti-PD-1 treatment. And the histology has been really described as an autoimmune-like colopathy, lymphocytic infiltrate plus minus plasma cell and eosinophils. There might be a microscopic colitis pattern, and the chronic injury may resemble IBD. So I hope over the next couple of slides, will give you some more pointers as to what some of the histological parameters may be to point you in the right direction. I thought this was some nice summary, especially for CTLA-4 colitis. Associated colitis in comparison to ulcerative colitis is that ulcerative colitis usually has more basal plasmacytosis as well as crypt distortion, and less apoptotic bodies, but those are, I would argue, weak indicators to really make the differentiation between the two entities. Now, importantly, the NCCN came out with guidelines for the treatment and management of immunotherapy-related toxicities. And I wanted to draw your attention to the fact that in the GI, when you have established diarrhea and colitis, they subdivide them into mild, moderate, and severe. And here's the follow-up for severe. And really, management decisions are being made based on the degree of severity that patients may have when they are suffering from immune checkpoint inhibition-induced colitis, which then, if that is the treatment suggestion, raises the possibility or raises the question, do we grade the colitis that we might have identified? And so last year, Dr. Pai and authors the paper as to the significance of histological activity measurements in immune checkpoint inhibitor colitis. And in this paper, we looked at 149 patients from different institutions, and we really created them based on the endoscopic grade, and then use that to also, in a joint fashion, look at the histological grading. And so we identified 3 activity patterns, which match as to what were previously reported, but I think are helpful to really highlight where you might find yourself when you entertain this diagnosis. So the first one is the acute colitis pattern, and it is, as the name states, truly an acute colitis. The second one is the microscopic colitis pattern, and has both lymphocytic as well as collagenous colitis-like changes. And then the last one is the dreaded one, the chronic colitis pattern, which is sometimes very hard to differentiate from IBD. So clinical history is your friend, both in knowing as to whether the patient had a previous diagnosis in IBD, as well as understanding the medication profile. And the classic pattern is you go into the pathology database and identify that the patient had a melanoma not too long ago, and then everything starts falling into place. And so in our cohort, we identified that really there was maybe a bit of a higher age range for the microscopic colitis, as well as having the median time to colitis was probably a bit higher, but it really did not lead to any statistical significance. So with that, and a bit early, I thank you again very much for entertaining me and for listening to me. And again, I'm so sorry that it had to be virtual, but I hope that at some point I can come and visit you. Thank you very much.